And thanks to Envara for allowing us to have a, sorry, my slides, let's say, a session and be together today. The disclosure slide's always important, and today I'll be talking primarily about the NIH study and some information from that, and about the related product now that's clinically available, Encala. So if we were all together, we would be standing in a big room or next to the poster. And really, most of the time, I wanted to talk about the new findings we have related to a new mechanism of action. And then as time allows, there's some updates on Encala. It has been available for clinical care now about 10 or 11 months. So there has been more experience and some other progress there. So I'm certainly not going to read through the poster itself, but that's posted independently, and I did do a little audio for that, and would like to recognize the core team, particularly Maria and Asim, who were a part of the original clinical trial, and Alyssa, who's been helping as we've continued to work through this data. So in the way of background, all of you know, being that we're at a CF meeting, that in CF, our patients with pancreatic insufficiency, or PI, still have some fat malabsorption, even when we optimize the pancreatic enzyme medications. And that's really been very well established. So trying to think about how to do a better and better job in this gap between what can we get with enzymes and how do we get to more normal patterns of fat absorption, which gets the calories in, which helps with growth and weight maintenance in adults. So the work that's really been done around Encala comes out of a very novel structured lipid matrix that is really based on the lysophosphatidylcholine component and the particular mixture of fatty acids for the essential fatty acids. And this was the product that was tested in the clinical trial, where the volunteers, the patients and their families came from 10 different CF centers around the US and traveled to CHOP here in Philadelphia and participated in the study. So the key element of all of this is with the structured lipid and the unique characteristics in digestion and absorption. The fat in Encala, in this product, is able to be absorbed without the need for lipase, the pancreatic enzyme digesting fat, nor for bile acids, which are normally essential, again, for formation of micelles and absorption. So you can think of Encala as acting like a micelle or acting as its own micelle and really driving efficient absorption of the fat that comes with the product. Today, really, what I wanted to talk about is something that we have been exploring and learning about over the last year, which is the new finding for this poster. So that there is also a mechanism where there is a recycling of the LPC, which really helps with absorption of other dietary fat. So I like to show the schematic to remind us really that it is a very complex structured lipid. This isn't just a triglyceride with fatty acids reorganized. It is driven by the LPC and then other long chain free fatty acids, particularly the two essential fatty acids. And then the rest of the molecule is made up by specific monoglycerides, all of which are long chain and deliver a lot of calories per gram. So when you can see when I talk about this as a micelle-like structure, this is the way that it naturally forms in the gut. And again, you do not need the lipase for digestion of triglycerides, nor the bile acids, which are an essential component of making the micelles. So the new information that really communicating is our team noticed that there seemed to be more fat absorption than that just from what was provided in the medical food in the Encala. And going back to the literature, was able to find information that really goes back over a decade, where there had been the discovery of MDR3. So MDR actually stands for multiple drug resistance, and it's an intracellular pump that returns complex molecules from the cells in the and if you will, the blood side of the gut, getting it out of the lumen. And this has been described in both the gut mucosa, which the diagram is on the left, and on the right, similar information coming from the liver and the bile ducts, where you get the same pump recirculating these large molecules. And this discovery really came out of work of looking at antibiotic and cancer chemotherapy drug resistance. And too much to go into today, but just to let it be said that one of the molecules that this pumps back into the intestinal lumen is LPC. And then that goes back to being able to take the Encala LPC that has been absorbed into the intestines as sort of the catalyst for movement. But the LPC is not where the calories are. So the calories from Encala go ahead and get absorbed and go to the lymphatic system and do the normal metabolism and physiology. But this MDR3 takes the LPC and other compounds and basically recycles it back into the gut. And that is the mechanism that the LPC going from the gut into the cells back to the gut is then available to support absorption of dietary fat. So not the fat provided by the Encala per se, but the accompanying food, because Encala is always taken with the patient's food and beverages. So with looking at this, we went back to find the data supporting it. And again, this is the essence of the poster. We looked at what we had from the big clinical trial, and we selected palmitic acid, which is a long-chain fat. It's 16 carbons long. It's saturated, so it's the C-0. And it is one of the most abundant fatty acids in the food supply and in our diet in the U.S. So it could that way represent something that would be commonly available in the intestines from the food that our patients are consuming. And in contrast, palmitic acid is a very small component of Encala and was a very small component of the Limixorb, which was the name of the product we used in the trial. So we decided to use that as sort of the marker to test this hypothesis. And in the table below, you can see we looked at, on the left, all subjects. So over 100 subjects in the study. And then because we've been working with this special group who had more malabsorption at the beginning of the study, on the right-hand side, you see that analysis. So looking at the C16 concentration in the blood, so this would be one of the, looking at it out of the plasma fatty acid data set. In the top, you see PLA, which is for the placebo, and LXS, which again was the name of the compound in the study. And you can see that, look, comparing baseline in 3 months, that we saw an increase of 24% of the palmitic acid and no change in those subjects who were randomized to placebo. And looking at that same approach, but in the subjects who had more severe malabsorption, you see the same pattern. So this is something that's happening really regardless of your pancreatic status, both in those who had healthier absorption and those who had the most severe absorption. The bottom set of the table just shows the same approach, looking at all fatty acids, not just the C16. So this is really quite substantial um, results to support the idea that the non-limb absorb or non-Encala fats are being absorbed at an increased rate. And then just to share this other bit of data that came out of some of our very early work, where we were using an experiment when we had carbon-13 labeled fats, and we tested them. This was with Dr. David Yasser, the inventor, in volunteers who had CF and volunteers who were healthy, and particularly looking at the green data that you can see in perfectly healthy adults. So they had healthy pancreases and liver and intestinal mucosa. When they were exposed to the structured lipid, they increased their absorption as well. So again, the food that they were eating under normal circumstances started to be absorbed at an increased rate. And the data shown in blue was the group of adolescents with CF. And in this experiment, they were not on pancreatic enzymes. And again, just showing the dramatic change of the increase of absorption. And again, this was a short-term study, just over a number of hours, but using the methodology of stable isotope labeling. So I wanted to, we'll take questions, and like I said, wanted to be sure we had plenty of time for that at the end. And what I would like to do, though, is just mention a couple of other updates, because like I said, the product has been out for about 10 or 11 months. The study that I did was focused on school-age kids, children from 5 to 18. And of course, so much now these days for all of us is with the advent of newborn screening. A big part of our interest is to be able to prevent or treat the growth faltering in very young children. And the other area that we as clinicians have really been focusing on is that subgroup of patients, which traditionally is about 10% of patients across the whole country. If you look at the CF registry data, those patients who have had enough nutritional difficulty to move to being tube fed. And the question of how might Encala help in that setting? In my clinical view, how could it help prevent going on to tube feeding? And then once you're on tube feeding, how can you meet your goal weight gain and help them taper off and get back to regular food? So these are the current recommendations, and much of this comes from your experience. This is, as I understand it, a very nice dialogue between the company, people who are talking with you and learning from you and sharing knowledge as well. But using Encala with tube feeding, with a water bolus, so that would be potentially using it as a flush before or after tube feedings, has been very successful and requires only a small amount of water, about 2 ounces. And again, this was started in my study. And then the other thing that has become used enough that there is a good deal of comfort is you also can mix the powder with the actual product and either give it as a bolus with the formula or over some continuous feeding time of the 4 hours. And again, things you're all familiar with, and fits into the use of gravity feeding or the enteral pumps that we use. So now really this is back to the emphasis on young children, because in my original study, we did not have young infants and certainly nobody on infant formula. We had a good bit of experience with tube feeding formulas, but now the Encala has been tested particularly with the commonly used infant formula, standard infant formula. And also, there are at least 2 formulas that were designed for premature infants after discharge, so that those formulas were designed to continue to meet the post-preemie growth and nutritional needs. So with this independent testing, again, more at the benchtop, testing the powder for how did it dissolve in these formulas, and how did it flow, both with breast milk and then with the specific products, and with various style popular nipples, because again, the idea of making it easy for the patients to take this. So out of that came some, the experience that you really can do what we often do clinically, is try to concentrate the formula from the 20 calories or 24 calories standard up, and are in a position to, increase the calories significantly, really to align with whatever your goals are. And then the other thing that I really was encouraging everybody, the company and all of you, to be thinking about is, of course, the other part is how do you add this to what we would, the typical solid foods that babies and toddlers are getting. So again, the Encala was tested with the various stages of baby food, which all of you know really has more to do with texture, and the both the commercial, well, in the commercial setting, the different stages, and looking at the food groups that we most commonly use, so cereals, vegetables, fruits, and meats. So that went very well. And again, this approach of adding it, just like you would have added butter or something else to the solid foods to get them to enhance the calories. One other thing that was that really was an early experience program was the ability to have a real dialogue with some of the patients early on. And this did, again, give very good feedback. I particularly looking at the patients who, when they started, said they had more severe symptoms, and that of those, they really did report improved symptoms. And then most patients really imported that they could sense an improvement in their digestion and the weight gain. And then really the last piece that goes to what we all spend a good bit of our time on is making sure that we can get our clinical products reimbursed. And again, appreciate that the company has done a good bit of work in this. And you can see here, I think the really big accomplishment recently was getting a specific code, a CMS code for Encala, which will help get reimbursement, help in the letters of medical necessity, and that there's now a really growing nice history of this being approved across different health insurance programs, including WIC.